Hello, welcome back. In today's lesson, I will discuss about portal vein thrombosis. The portal vein originates posterior to the neck of the pancreas from the confluence of the superior mesenteric vein and the splenic vein. It supplies approximately 75% of blood to the liver and is a valveless vessel. Its predominant function is to carry nutrient-rich blood from the gastrointestinal tract to the liver. Portal vein thrombosis develops in the trunk of the portal vein itself or in either the right or left intrahepatic branches, sometimes extending down to the superior mesenteric or splenic vein. There are different classification systems for portal venous thrombosis. The first one is acute and the chronic classification. Portal vein thrombosis is classified as acute if symptoms appear less than 60-day period to hospital assessment. More than 2 months symptoms before hospital evaluation is called chronic portal vein thrombosis. The classification system used for portal venous thrombosis is the Yerdell classification, which considers both the degree and the extension of the thrombosis. Portal vein thrombosis can also be categorized according to the presence or absence of cavernoma. So, when we see the classification of portal vein thrombosis based on the extent of thrombosis, we call it minimal thrombosis if the thrombus covers less than 50% of the diameter of the lumen, and we call it total occlusion if it is greater than 50%. And complete occlusion or total occlusion is classified as complete thrombosis of portal vein and the proximal superior mesenteric vein, and also complete thrombosis of portal vein and the proximal and the distal superior mesenteric vein. The other is based on associated liver disease or based on cavernoma formation. Type 1 is partial thrombosis without cavernoma. Type 2 is partial thrombosis associated with cavernoma. Type 3 is complete thrombosis without cavernoma. Type 4 is complete thrombosis associated with cavernoma. When we see the etiopathogenesis of portal vein thrombosis can develop similar to the formation of thrombus in any other vessel, which can be explained by virtuous triad, endothelial damage, stasis, and hypercoagulability. Endothelial damage can occur in patients who have a liver pathology, such as cirrhosis, or because of vessel damage from surgical procedures. Stasis can be secondary to a tumor compressing the portal vein and also sluggish flow in this vessel because of other reasons. Whereas, since the portal vein is the principal transporter of nutrient and other components from the intestinal circulation to the liver for metabolism, any factors that may slow down this flow could lead to thrombosis, such as intestinal infections. Some hematologic conditions, including hereditary thrombophilia, can increase the risk of thrombosis by being a hypercoagulable state. Regarding clinical presentation of portal vein, majority of them are asymptomatic, so you can miss them till they develop some symptoms from either collateral circulation or development of varices. Right hypochondral pain, which can be acute onset or long-standing. Splenomegaly with ascites, because splenic vein drains to portal vein. This causes huge burden or accumulation of venous blood on the spleen, causes splenomegaly. And unexplained abdominal pain, features of intestinal ischemia, occult bleed in stool due to bleeding from the varices, and unexplained gastroesophageal varices, abrupt worsening of ascites or hepatic encephalopathy. Regarding the diagnosis of portal vein thrombosis, from the imaging, the most common imaging technique used for the diagnosis of portal vein thrombosis is Doppler ultrasound, with a very high sensitivity in most studies. CT and MRI have the additional advantage of being able to define the extent of the thrombus, show any evidence of bowel ischemia, and for looking at other organs surrounding the portal vein. All patients with portal vein thrombosis should undergo a gastrointestinal endoscopy to exclude the presence of varices, which may be in the esophagus or the gastric mucosa. These varices need to be identified because they are important in planning management for the following reason. The first one is the need for anticoagulation, which has to be balanced with the bleeding risk from the varices. Choice of anticoagulation may depend on the bleeding risk for varices and the reversibility of the anticoagulant. and ability to cure the varices may impact on long-term anticoagulation management. Blood tests do not usually show any significant to suggest portal vein thrombosis, but on complete blood count, we might see anemia if there is bleeding, and liver function tests are usually normal unless there is cirrhosis or any other liver disease. The alkaline phosphatase may rise, however, if there is portal hypertensive valvulopathy developing as a complication. As in general, the case in venous thrombosis, D dimer is usually increased and not helpful. It is important to exclude any underlying systemic disorder in those with no local cause identified. So, all patients without a clearly identifiable cause on imaging, on ultrasound, or CT or MRI should have JAK2 mutation, factor V Leiden mutation, prothrombin gene mutation, antithrombin deficiency, protein C and S deficiency, antiphospholipid syndrome, paroxysmal nocturnal hemoglobinuria, and vasculitis including Behçet disease, and the methylene tetrahydrofolate reductase and the plasminogen activator inhibitor type 1 gene mutation should be determined. Regarding treatment of portal vein thrombosis, the first one is we should have to assess for bleeding risk, such as varices, concomitant antiplatelet agents, or drugs that causes additional burden of developing bleeding. And if bleeding risk is low, start therapeutic anticoagulation with low molecular weight heparin. If varices is likely to be present, such as history of hematemesis or non-cirrhosis, refer to gastroenterology to see if definitive treatment is possible, such as banding, and commence anticoagulation when safe from bleeding risk point of view. If symptoms suggest or imaging confirms intestinal ischemia, refer to surgeon for intervention. Meanwhile, start intravenous unfractionated heparin since interruption of the anticoagulant may be required for surgery. Monitor the heparin infusion with anti-factor 10 if activated partial activated PTT is abnormal prior to commencement because of concomitant liver disease. If thrombus extends while on adequate therapeutic anticoagulation, consideration should be given for thrombolysis. If very high bleeding risk is a contraindication for thrombolysis, surgical intervention might be sought. In patients with decompensated cirrhosis and portal hypertension, consideration should be made for transjugular intrahepatic portosystemic shunt. This is all about portal vein thrombosis. Thank you for watching.